non-alcoholic fatty liver disease. So I know that this disease has been long considered as a very boring disease affecting boring people who eat too much. And it's boring because there is no treatment, so it's not used to talk about non-alcoholic fatty liver. Actually, it's not true, so I will try to convince you that it's a very exciting subject because number one, it's a global concern. Number two, we will see that it's an increasing condition in HIV subjects. And it's a potential serious disease and a deleterious hepatic cofactor. And it's not true. There is a place for treatment. So first of all, what is non-alcoholic fatty liver disease? Non-alcoholic fatty liver disease is defined by the accumulation of fat, of triglycerides, inside the hepatocyte. It encompasses two entities, simple steatosis and NASH, non-alcoholic steatohepatitis, that is defined by the presence of steatosis with inflammation. Non-alcoholic fatty liver disease is closely associated to what we call the metabolic syndrome. So that's why you can also hear the word metabolic liver disease. But what is a metabolic syndrome? It is an association of metabolic factors, and you need 3 parameters among the 5 following parameters. So central obesity, high blood pressure, low cholesterol, HDL, high triglycerides, and high blood glucose. If you have 3 parameters among these 5 parameters, you can consider that your patient has a metabolic syndrome. I will not go into details on the physiopathology because it's very complicated. But what I can tell you is insulin resistance is the key actor. To be very simple, when a patient is obese, there is insulin resistance that will induce lipolysis from the adipose tissue, and this adipose tissue will release a large amount of fatty acids to the liver. And in parallel, you have a high amount of insulin, which will induce lipogenesis, and the result is an accumulation of triglyceride inside the liver. So insulin resistance is very important. That's why we try to assess insulin resistance in patients who are suspected to have metabolic liver disease. It's not a perfect index, but what we use is this OMA index that combines glucose, insulin divided by 22.5. And over 3, we consider that patients are insulin resistant. So it's a global concern. Indeed, as you know, there is an epidemic of obesity and metabolic syndrome all over the world, and not only in the United States, but also in the UK, in France, in Middle East, even in Africa, where obesity can reach almost 20% of the population. In this context, as I told you, non-alcoholic fatty liver disease is closely related to obesity and metabolic disorder. It's not surprising to see a high prevalence of NAFLD and NASH all over the world. And again, not only in the United States, but also in Japan, in India, where 1/3 of the population is considered to have non-alcoholic fatty liver. And in the United States, we see an increased indication of liver transplantation for NAFLD and NASH. So environmental factors and eating habits are the main cause of obesity, metabolic syndrome, and all over the world, the McDonald's epidemic, even in Africa. But is it the only factor? What we know is NAFLD is more common in some ethnic groups, and particularly in Hispanic people. So we can suspect that there are genetic factors. This is a very interesting study that has been published in 2010, I guess, and the study included a large number of patients were divided into 3 groups of ethnic groups: Hispanic, Afro-American, and European Americans. All the patients had a spectrometry to assess the liver fat content and a genomic analysis. And the author found a relation between this gene that encodes for a protein called adiponutrin. Adiponutrin is involved in the synthesis of triglycerides. And so they found a specific polymorphism of these genes in some population, and in particular in Hispanic population. So definitely there are also genetic factors involved in the development of non-alcoholic fatty liver disease. What about HIV subjects? As you know, since the introduction of antiretroviral therapy, HIV individuals are getting older but also fat. As you can see in this slide, over the time, HIV people, more than half of them are now overweight and obese. It was in this American study. This Italian study included more than 1,000 HIV patients, and they compared the patient to controls, and they found a higher prevalence of metabolic syndrome in HIV subjects, as you can see here. But the most important parameter were lipid abnormalities and glucose abnormalities in HIV subjects. Insulin resistance is also quite frequent in HIV. Even in non-treated HIV patients, we found 12% of insulin resistance, and 13 to 50% of insulin resistance has been reported in HIV-treated patients. Even severe insulin resistance may concern 37% of HIV-positive subjects. And this study compared to non-HIV subjects. And after adjustment for adipose tissue and other metabolic parameters, these HIV subjects seem to have more frequently insulin resistance. The reason of developing insulin resistance in HIV subjects remain unclear, but there are probably a lot of parameters involved in the development of insulin resistance and metabolic factors, but probably the virus itself and the drugs may induce mitochondrial dysfunction, endoplasmic reticulum stress, inhibition of autophagy, and adipose tissue disorders. Of course, I will not get into details because it's also very complicated, but you can see that there are a lot of reasons to develop insulin resistance and metabolic disorders in HIV subjects. As I told you before, there is a relationship between insulin resistance, metabolic disorders, and steatosis. So it's not surprising to see high prevalence of steatosis and NASH in HIV. Some studies reported 30 to 40% of simple steatosis in HIV-positive subjects. And other studies showed 30 to 57% of NASH. I told you NASH is the association of liver steatosis and inflammation. And finally, using liver biopsy, these studies reported also a significant proportion of severe liver fibrosis, 20 to 30%. The problem of these studies, of course, they included a small number of patients because it's difficult to do liver biopsy in these subjects. But that's interesting. And it's very interesting, so we decided recently to apply for a grant to better assess the severity of metabolic-related liver injury in the European cohort of HIV subject. Is it a problem or is it not a problem? So we will try to answer this question through this large multi-center study, which will include France, Belgium, and Germany. I hope I will be able to give you some results in the coming years. So why talking about non-alcoholic fatty liver disease? Because it may be a serious disease. Most of the studies demonstrated that simple steatosis is a benign disease, but in some cases, in 15 to 20% of these patients, they will develop non-alcoholic steatohepatitis, I mean inflammation plus steatosis. And some of them, between 13 to 38%, will develop significant fibrosis with a risk of cirrhosis and liver cancer. This table summarizes the main studies about the natural history of non-alcoholic fatty liver disease. And as you can see, fibrosis can decline or remain stable in the majority of patients. But in some cases, in about 30% of the cases, patients will develop more severe liver fibrosis. And what are the risk factors of fibrosis in this population? Some studies reported age over 50, high BMI, high diabetes, of course, all the high parameters of metabolic syndrome. But it appeared that age may be an important factor of liver fibrosis. Another important result is the low survival of patients with non-alcoholic fatty liver disease. In this American study, including 420 patients with a mean follow-up of 7.6 years, the overall mortality was 12.6% and the survival, if you compare to the general population, was lower. And it's interesting because liver accounted for a large proportion of deaths. It was the third cause of death in this population. This is another important study published in 2011, so quite recent, that included 257 subjects. And this message is very important. Fibrosis, the severity of fibrosis was the independent factor of liver-related mortality. So assessing fibrosis in these subjects is very important. If you suspect a non-alcoholic fatty liver disease in patients, you have to assess in priority the degree of fibrosis. So you will tell me it's impossible because it's impossible to do liver biopsy to all the patients we suspect metabolic liver disease. So is there an alternative to liver biopsy? Yes, there is, and this is the use of FibroScan. Is it possible to use this non-invasive machine for these patients? And I refer to this interesting study who included more than 200 subjects with liver biopsy, and the authors proposed this cutoff as 7.9 kilopascal to suggest significant liver fibrosis. So maybe FibroScan could select specific patients, the most severe patient that may be candidate for liver biopsy. So non-alcoholic fatty liver disease is also a bad hepatic cofactor. Indeed, in obesity and insulin resistance are now considered as chronic inflammatory states, and it has been shown in vitro but also in vivo that insulin resistance promotes fibrogenesis. And in HCV-infected subjects, insulin resistance has been demonstrated to be associated with the severity of liver fibrosis. In HCV-infected patients, obesity is also associated, and insulin resistance as well, with a poor response to antiviral therapy. It is also associated with a reduced probability of achieving SVR. These metabolic factors seem to play a role as well in carcinogenesis. It has been suggested in HCV-infected patients, but also just in obese patients. The relative risk of obesity was an independent risk factor of liver cancer. And in non-cirrhotic patients, HCC may be associated with steatosis in more than 0.5% of the patients. The accumulation of visceral fat has been also identified as the risk of recurrence of HCC in non-HBV and non-HCV and non-alcoholic patients. The link between insulin resistance and liver carcinogenesis needs to be more investigated. In HIV also, very recently, a French study, has demonstrated that the degree of insulin resistance may be associated with a higher risk of liver cancer. Is there a place for treatment? That's a difficult question because to date, there is no efficient drug to treat non-alcoholic fatty liver disease. But you can try first very important measures. First, the treatment of associated metabolic disorders, diabetes, high blood pressure, lipid abnormalities is very important. Weight loss and exercise are very important also. It is difficult to demonstrate that weight loss can improve non-alcoholic fatty liver disease and NASH, but there is this study including only 31 overweight subjects. The patients were divided in two groups. One group was treated just by weight loss, and they lost about 7 to 10% of weight, and the other group received a standard diet. They had a biopsy at baseline after 1 year, and as you can see, after weight loss, steatosis improved with a significant difference, and NAS score that assesses the severity of NASH was also improved after weight loss. It's also important to avoid some diet, and there is something very fashion. It's the fructose that is included in corn syrup. Corn syrup is added in a lot of soda and industrial food to get good taste. It has been shown in mice, but also in patients with NASH, that consumption of fructose may be associated with severe liver inflammation, and also it may be a cofactor of liver fibrosis. Exercise is also very important, and it seems to be independent of the weight loss. In this study, it's a very small number of patients, but it's interesting because patients were very well assessed for fatty liver content, and exercising improved significantly insulin resistance and steatosis. So a lot of drugs have been proposed as treatment for metabolic liver disease, like glitazone, because they can correct insulin resistance, and they have been used for the treatment of diabetes during a long time. The problem with these molecules is first the weight gain, second the cardiac toxicity with some of them, and recently, as you know, the pioglitazone has been withdrawn from the market because this drug seems to induce bladder cancer. So for the glitazone, it's probably the end as a treatment in non-alcoholic fatty liver disease. This study is very important. It has been published in the New England Journal of Medicine in 2010. A patient had a liver biopsy at baseline, and after 96 weeks of treatment, and they received placebo or vitamin E or pioglitazone. And the results are very interesting because vitamin E seems to be effective to improve inflammation, not fibrosis, but at least inflammation. If you compare vitamin E with pioglitazone, vitamin E may be effective as pioglitazone with a lower price. I will just finish with this molecule, ursodesoxycholic acid, that is Ursolvan or Delursan, at least in France. And this molecule is interesting because it has anti-inflammatory effects, but this drug may have also metabolic positive effects. And this is a study from Vlad Radzu, published in 2011. And he used high dose of ursodesoxycholic acid, and in this study, patients improve glucose, insulin, and insulin resistance. Some studies tested the association of ursodesoxycholic acid and vitamin E with interesting results, like improvement of transaminases, steatosis, inflammation, and insulin resistance. In practice, the European Association Conference for Liver Disease suggests to treat first the most severe patients, and they mean by most severe the patient who has significant liver fibrosis. And they suggest to treat this patient with exercise and diet, and also they propose to treat this patient with ursodesoxycholic plus vitamin E. This is a suggestion. So just to conclude, metabolic syndrome and non-alcoholic fatty liver disease have reached epidemic proportions, and it can lead to cirrhosis and liver cancers. Patients with NAFLD have a lower overall survival, and it is a cofactor of liver fibrosis. And maybe NAFLD could emerge as a potential serious condition in HIV subjects. It has to be confirmed. Lifestyle, diet, and exercise are crucial therapeutic measures, but we need, of course, more trials to validate efficient drugs. But at least you can keep in mind that we can use vitamin E, and why not in association with ursodesoxycholic acid as a treatment for the most severe patient.